So I'm going to give you in 5 minutes a look from inside an academic medical institution. Next slide after this one, please. Next slide. So I'm going to give you an idea of what happens in an academic medical center if you take the point of view of, okay, we're under the influence of all these regulations and agency guidelines that we want to adhere to. How do we try to move innovation forward? So the challenges that's in front of all of us is, as you know, there's a very low pay line at NIH now and a need at universities for new avenues of funding. You heard from Todd Shearer about commercialization of intellectual property. You could have more aggressive philanthropy. But the intensification of government regulatory activities on our scientists and clinicians for all the things that are listed there, radioisotopes, recombinant DNA, human subjects, and so on, it is a burden for all of them, whether or not you're going to argue that the new conflict of interest and the rules from the NIH and the Sunshine Act are inhibitory. There's a lot of regulatory environment already. Next slide. So why do you want to have a commercial focus? Well, the obvious reason is some of what Todd mentioned. It generates benefit to society, improves the lives of patients, and it's a revenue source for the institution. In our institution, we're a very innovative organization. We have a CEO who has a lot of patents and has been a very active innovator. So we want Cleveland Clinic to be known as an innovative institution. We want to be able to recruit and retrain and to retain and reward an innovative staff. And we also want to secure resources through this to enable reinvestment in a stable environment. And of course, there's fallout for economic renewal in a city like Cleveland. Next slide, please. So just a couple of micro things. We have a very, very aggressive commercialization arm. In the last, I think these are 10-year data, we have 1,800 patent applications, 425 issued patents, 450 product licenses. We've spun off 55 companies, and we have a large staff. Next slide. So what do I think drives innovation in Cleveland Clinic? Why is it successful? Why does it move forward? I think we have an innovative faculty, and it's stressed as a valued activity. We also have in Toby Cosgrove and Joe Hahn leadership that supports innovation. And key to this is that the leadership supports the conflict of interest management as well. They're very generous with resources toward what we call the Innovation Management and Conflict of Interest Program. Very important in all of this is buy-in from the faculty for conflict of interest management. We've taken a lot of effort to talk directly to faculty members who are involved in innovation and to have a COI program that's collaborative with the inventors and works with them to get them through and understand the ethical environment. Next slide. So what's the process we go through? In broad brushstrokes, we go through every funded grant. And we have a weekly meeting where we do that, and we look at the specific aims of that grant. We have all the investigators listed, and then we have all the disclosures coming into us from those investigators on what companies they have affiliations with. We have a zero de minimis for reporting, so we have all of their industry ties. Then we have the websites of the companies that are among those companies that are there. And we ask ourselves, is there any way that these specific aims could be related to the products of these companies? Then we immediately get in touch with the investigator and open up a dialogue where we educate the investigators about what is conflict of interest in a modern regulatory sense and in an ethical sense. And we work with those investigators to define whether or not they have a conflict and to educate them about that, tell them what the reporting requirements are going to be for that. And in so doing, we take on some of the burden of compliance for the faculty, and we help walk them through the regulatory environment related to conflict of interest. Next slide. So then we would spend a lot of effort managing conflicts of interest. And obviously in managing conflict of interest, you want to separate the possible influence of industry money from the integrity of data, the validity of research decision-making, and the well-being of research subjects. And we spend a lot of time on this. And the next slide shows some of the management tools that we use. Broad disclosure in any presentations, any publications to all your colleagues on that research project. And then we, in certain cases, we reassign data analysis to another group that doesn't report to the conflicted investigator and isn't conflicted themselves. We have a lot of investigators who have read-only access to their data and other restrictions in the collection and the analysis of data. We have the rights to independent data audit in any of these products and any of these projects, and we can put another physician in charge of final approval of subject selection and consent, and we can ask for external data safety and management. We have purchasing restrictions, and then we have trainee protections where we don't let a trainee who's under a conflicted investigator be subject to any publication restrictions or anything like that. Sometimes we impose authorship limitations. So this is a short list of things we can do to manage conflicts of interest, and we have very, very good relationships with all the investigators who are involved in this. We don't get any pushback. We get a lot of collaboration and cooperation. The investigators want to publish data that they can claim is free of risk of bias. Next slide, please. So I just wanted to comment on the new NIH regulations. There are 11 or 12 of these that are really prescriptive and affect the way we do business at the Cleveland Clinic. Some of the rules that came out of the NIH that I think are extremely beneficial is that the institution, not the investigator, decides whether there's a relationship or a financial conflict of interest. We're in favor of public disclosure and have been doing it on our own for a while, so that the public disclosure that was part of the rule we were also in favor of. The cons are that the extra work and resources for uncertain benefit of some of these regulations have us adding new staff and for example, reducing the de minimis from $10,000 to $5,000 for defining significant financial interest. We had in our database twice the number of investigators that had between a link to a company between 5 and 10 as over 10. So if you do the math on that, it tripled our workload for scrutinizing disclosures. And then we're having to monitor industry-sponsored travel, which I think is very little bang for the buck. The good news is that the AAMC, as you heard from Heather this morning, is gathering metrics to look at the impact of the regulation and both resource allocation and also impact. Is that the last slide? Thanks very much.
Thanks, Guy. Next, we have Margaret Anderson for Foster